Welcome back. So this is part 2 of lecture on twin pregnancy. We'll start with by saying that twin pregnancies are at increased risk of having a preeclampsia. Okay, we will discuss other possible complications in a later slide, but to begin with, we should know that it's a moderate risk factor. Okay, so twins or triplets, that's a moderate risk factor. That means until and unless, so if the patient has another moderate risk factor, for example, if it's a first pregnancy or her age or BMI or a family history of preeclampsia, if there are at least two moderate risk factors, then we have to start aspirin, and we know that it's low dose aspirin. Okay, so just remember it's a moderate risk factor, it's not a major risk factor. Okay, so early in the pregnancy, if you remember, we said that the first sign of pregnancy on an ultrasound, that we first see a gestational sac. Okay, so the main difference in this picture and this picture is, here we see one gestational sac, here we see two gestational sacs, and here we can see also two yolk sacs as well. Okay, and we know that yolk sacs develop before development of a fetal pole. Okay, so we know that this is a diamniotic pregnancy and this one is a monoamniotic pregnancy. We cannot say what will be the number of placenta in this pregnancy, the diamniotic pregnancy. Why? Because each baby may have their own placenta or they may be sharing one placenta. So in this one we do not know. Placenta develops later, right? So we do not know. However, in this monoamniotic pregnancy, you can guess easily the number of placenta. It will be just one placenta because it's against the rule to have one placenta, two placenta and one amniotic sac, right? So for one amniotic sac, there will be only one placenta. But for two amniotic sacs, there will be at least one placenta, but it may be two placentas, okay? And by the way, if it's a conjoined pregnancy, we can even see conjoined twins even at this stage, okay, very early on. Now, what is the best time to differentiate whether it's a monochorionic twin pregnancy or dichorionic twin pregnancy? It's at NT scan actually, between 11 to 14 weeks, that's the best time. And if we see certain signs which are either called lambda sign or T sign, that differentiates whether it's a monochorionic twins or dichorionic twins. Some patients who present later, in those patients, because the pregnancy has grown, now these signs may be lost. Okay, so if someone asks you what is the best time to determine the type of twin pregnancy or determine chorionicity of pregnancy, that's 11 to 14 weeks. And whenever we see these signs, we have to take images and save them in the patient records. Okay, what are the signs? Lambda sign. Lambda, if you remember, I think it's a Greek word, Greek letter actually, right? The lambda, like sigma, lambda, delta, one of those letters. And so this is actually named because it looks it's called the tongue of placental tissue. So two placentas, they're coming together and they form this tongue of placental tissue, and when we see this lambda sign, that means it's a dichorionic twins. Okay, but if we don't see this lambda sign and instead we just see these two amnions, right? So this is one amniotic sac, this is the other amniotic sac, but we are not seeing any this tongue of placental tissue. So it's called a T sign, and then it's a monochorionic twins. Okay, so that's how it is determined. So then there is a phenomenon which is called vanishing twin syndrome. That means that initially a pregnancy started as a twin, but later on just one baby develops, the other one it's kind of resorbed. Okay, the patient may not have any bleeding. Okay, so one baby just kind of degenerates. Okay, so or vanishes, and the second baby, they continue to develop as normal. Okay, so there is that's it. We just write in the notes that, oh, it's a vanishing twin. Initially we were able to see two babies, but now one has developed, and that's it. Okay, now these complications, that's for all types of twin pregnancies, but there are some types of twin pregnancy which are more at risk, and there are some complications specific to monochorionic diamniotic twins. We will talk about them. These are the ones. But in general, compared to a singleton pregnancy, twins pregnancy, they are more at risk of developing complications which may be related to fetus or may be related to the mother. Okay. So related to the fetus, monozygotic twins compared to dizygotic twins, they are more, both of them actually, they are more at risk of having congenital anomalies. Okay. Then these babies are more at risk of going into preterm labor because the uterus is overdistended, right? And which may be spontaneous labor or iatrogenic labor. Iatrogenic means the doctor induced because or performed a C-section because it was dangerous to continue with the pregnancy. Okay. We have a separate lecture on preterm delivery, but if the baby delivers preterm, they are more at risk of having respiratory distress syndrome. This is intraventricular hemorrhage in the brain, okay, in the ventricles of the brain, necrotizing enterocolitis that is related to bowel of the baby, increased perinatal morbidity and mortality, of course, sepsis. And there are some other complications which we will discuss in a separate lecture. And one or both of the babies may have fetal growth restriction. They may be conjoined. And when do conjoined babies happen? If you remember it, if only they are in the same amniotic sac, okay? The babies, one of the babies or both of them can die. But if one baby passes away, even the surviving twin, they are at risk of increased cerebral palsy. And by the way, babies who are born preterm, they are also at risk of having cerebral palsy. Okay. Now, if the babies were sharing one placenta, there are certain complications, especially if it's a diamniotic twins, okay, like they're in separate amniotic sacs. But if the placenta is sharing, then they can have something called twin-to-twin transfusion syndrome. Again, some babies with this twin-to-twin transfusion syndrome, they can develop more complications called twin anemia polycythemia sequence or twin reverse arterial perfusion syndrome. We have separate slides, so we will discuss this again. Then all pregnant women, they have minor symptoms of pregnancy, which means pain in breast, they feel bloated, they can have nausea and vomiting, they may have shortness of breath, especially in the late third trimester. They can have acidity, they have constipation. These are all called minor symptoms of pregnancy. So all these minor symptoms of pregnancy, they are exaggerated if it's twins, okay? And women are more likely to have hyperemesis gravidarum. Women are more likely to develop deep venous thrombosis. Twins, pregnant women with twin pregnancies, they are more likely to develop anemia, antepartum hemorrhage, so they are more at risk of developing placenta previa because there are two placentas, right? There may be two placentas, so the surface area is more. They're more likely to have placental abruption, gestational diabetes, gestational hypertension, increased risk of operative delivery. Operative delivery means either delivering by a C-section or forceps or vacuum, okay? In increased risk of postpartum hemorrhage. Now, why increased risk of postpartum hemorrhage? Because the uterus is over-distended. When the uterus is over-distended, so after delivery of the babies, the uterus does not want to come back to its normal size. It does not contract, and then they can have uterine atony, which can lead to postpartum hemorrhage. Okay. By the way, I have taught you all of these: nausea, vomiting of pregnancy, hyperemesis, venous thromboembolism, anemia, APH, GTM, gestational hypertension, and not operative delivery, but increased risk of postpartum hemorrhage. We have covered all of these topics in your previous years, so please go back and revise them. Okay, so now we will talk about monochorionic twins mainly. Okay, so it is important to understand that majority of these monochorionic twins, like when there is one placenta, right, they have vascular anastomosis on the placental surface. They connect the two circulation. What do we mean by the two circulation? So if there are two babies and they are sharing the same placenta, so blood vessels of one baby, they are likely to be connected to the other baby. Okay. Now, there are different types of these anastomosis. Okay, there are three types actually. First is arteries of one baby, they are connected to the arteries of the other baby. Those are called arterial or AA arteries. Second one is arteries of one baby, they are connected to the veins of the other baby. That's called AV anastomosis. The third one is veins of one baby is connected to the veins of the other baby, which is called VV. Okay. Now, whenever there are these anastomosis, the circulation may be unidirectional or bidirectional. Okay, bidirectional means the circulation can go in both ways, like to both babies, right? Unidirectional means it is only going in one direction, like from one baby to another. Okay, and and superficial means that they are on the surface of the, like, so surface of the placenta. Okay, so arterial and veno-venous anastomosis are superficial and bidirectional anastomosis. Veno-venous anastomosis may be associated with decreased perinatal survival and cause demise because of sudden changes in venous return. In any case, okay, so now we are going to discuss this twin-to-twin transfusion syndrome. So, twin to twin transfusion syndrome happens only in pregnancies where there is one placenta, so that means monochorionic, but they have different sacs. So, the amniotic sacs are different, that means diamniotic. So, monochorionic, diamniotic twins can develop twin to twin transfusion syndrome. What happens in twin to twin transfusion syndrome is there are arteriovenous anastomosis. So arteries of one baby, they are connected to the veins of the other. Okay, so and it is unidirectional. So blood flows from one baby to the other one, like from, okay. So the unidirectional. Okay, so see, because and these babies are same sex, that means they are what in origin? Monozygotic. Okay, now there are different stages. There is a staging system which is called Quintero staging. The next slide we will discuss Quintero staging. There are 5 stages. So initially what happens, there is a donor baby and there is a recipient baby. So donor baby is the supplier, right? So what happens when the donor baby has less fluid, right? So as a result, we notice oligohydramnios in that sac. And the recipient baby, because he's receiving more blood, so what will happen? And more fluid, right? So that baby will have polyhydramnios. So what will be the situation? There is oligohydramnios in one sac and polyhydramnios in the other sac. Also, where does this amniotic fluid come from? We know that it's the urine of the babies, right? So, and where does urine come from? It comes from the urinary bladder. So, the baby having polyhydramnios, what will we see? The bladder, urinary bladder of that baby will be full. And the donor baby, which is giving, right? So because that baby had oligohydramnios, because that urinary bladder is not full. Okay, so the baby who is donor, the urinary bladder will be empty or may not be visualized, and there will be oligohydramnios. The recipient baby, there will be polyhydramnios and the bladder will be well visualized, okay, initially, and then things start to get worse. So there may be Doppler changes. Okay, Doppler ultrasound basically shows us blood flow, right? So blood flow. So there will be later stages, there will be problems in the Doppler ultrasound, and later on what happens, there may be high drops. When does high drops happen? When usually there is heart failure, right? One of the causes actually is heart failure. So when there is severe anemia, heart failure, then fetal high drops happens. So usually at what stage twin to twin transfusion syndrome happens? It happens as early as 16 weeks. So that's between 16 to 24 weeks. Okay, so that means we have, if there are twin pregnancies of monochorionic diamniotic twins, we have to keep an eye, keep monitoring, start monitoring very early. Okay, do not wait till say 28 weeks. Now, this is the Quintero staging. You do not need to memorize this, but see, in stage 1, the donor bladder is visible. So it's not too bad, right? So still we can see the urinary bladder of the donor baby. And later on, what will happen in stage 2? This donor baby, we cannot see the urinary bladder, but normal Doppler ultrasound in stage 3, what will happen? One or both babies, there may be abnormal Doppler ultrasound. Stage 4, by the way, we have another lecture on intrauterine growth restriction, so we will discuss about Doppler there. Okay. In stage 4, there will be high drops in one baby. In stage 5, either one baby dies, passes away, or the other one passes away. Okay, I'll stop here and then rest the treatment options for twin to twin transfusion syndrome. We will discuss in the other lecture, but I can see. So here, see, this one is polyhydramnios, right? So there is in twin A, there is a lot of fluid around the baby. Okay, so this is the recipient, right? And if we do not see much fluid around the baby in the second twin, right? So it looks stuck. So that's because of oligohydramnios. Okay.